Hello everyone, and welcome to another lecture in the Surgtest General Surgery Immersion series. I am Eham Arora, and today we're going to be discussing intestinal obstruction, which can be a very important and interesting topic for several reasons. The first of which is that there are several different pathologies that actually manifest with bowel obstruction. The clinical presentations are very variable. You need to have a reasonable clinical acumen to not just correctly diagnose the problem, but also determine the timing of intervention. And the last of which is that there are several surgeries from which you have to choose from correctly. All of this is required not just to pass the exams, but also to be able to give your patients a good post-surgical outcome. There are several easy ways of classifying intestinal obstruction. The main of which is dividing it up into mechanical causes and functional problems. Now, when you have a mechanical cause, it means that there is a physical barrier to the forward propulsive motion of intraluminal contents within the intestine from proximal to distal. It's essentially that there is a long pipe and there's a block somewhere in the middle of the pipe, make it very easy. But when you're dealing with a functional obstruction, well, there you don't have any physical impediment, but the function of the intestinal small muscle has been compromised for several reasons we're going to be discussing soon, as a result of which the luminal contents are not able to move from proximal to distal. Another easy way of classifying it is dividing it into simple, where vascular supply has not been compromised, and strangulated obstructions, where vascular supply has actually been diminished, so the bowel wall is ischemic and will eventually perforate. Another simple way is to divide it up into proximal obstructions and distal obstructions. This, of course, depends upon where the pathology is located. Even though the pathophysiology stays the same, the patient's clinical presentation and progress is very varied. We're going to talk about it in just a bit. And the last one is complete obstructions and partial or incomplete or subacute obstructions. In a complete obstruction, eventually the patient has obstipation, which means they are not passing any feces or flatus. The obstruction is complete, so none of the proximal contents are able to find their way distally. Whereas in a partial obstruction, these cases usually have some passage across, say, a stricture or a waxing and waning type of obstruction. So these patients are not as severe, but may eventually require some intervention. Now let's talk about basic pathophysiology, which is the same for small as well as large bowel obstruction. Okay, you can see a nice loop of the intestines, which are going from left to right. Say I want to obstruct this for whatever reason. I'm feeling particularly sadistic today. So we create this impediment. Now, over a period of time, because nothing is able to move from left to right or from proximal to distal across this little obstruction, we'll end up having a dilatation of the proximal segment. Now, because the bowel is dilating, the body has a way of sitting and trying to overcome their obstruction. Okay, so what it does is it increases the peristalsis in all of the small bowel at all levels. So at this point, the patient starts developing colicky pain as a result of the exaggerated peristalsis. Now, you'll notice that the peristalsis is also increasing distal to the obstruction, as a result of which this patient is now going to have diarrhea, where all of the distal luminal contents are being evacuated because of this hyperperistalsis. Now, this is a little bit of a confounding factor, right? You have a patient with intestinal obstruction that presents to the ER with abdominal pain and diarrhea. Don't be quick to dismiss these guys as enteritis or gastroenteritis. These can definitely be the early signs of a complete obstruction. Now, over a period of time, what's going to happen is the obstruction is absolute. it gets worse. The proximal segment dilates even further, and you'll notice that over a period of time, these peristaltic waves, they go away. So in a patient who had colicky abdominal pain, when their pain suddenly subsides, that's usually a sign that the obstruction is progressing reasonably fast. Now, the other thing I want to discuss about is the cause of the proximal distension. What exactly makes this up? Well, the first thing is the secretions that are normally present within the bowel lumen at all times. Now, these secretions may be salivary, they may be gastric, biliopancreatic. If you just think about what the secretions are like, salivary secretions are 1 liter a day, gastric secretions half to 1 liter, biliopancreatic about 1.5 liters a day. Just by itself, there's a tremendous amount of volume that's coming into the intestine, even if the patient isn't eating or drinking, right? On top of that is the patient's intake. Now, whenever the patient takes in even a small sip of water, there's going to be swallowed air that goes in. Even when they swallow saliva, there's some amount of air that goes and trickles in. So a lot of the gaseous distension that occurs proximally is swallowed air. But it's not just swallowed air. That's primarily composed of nitrogen, because remember, oxygen and carbon dioxide go across the lumen. So all that mostly remains is nitrogen. There's also air from fermentation. All of the bacteria within the proximal bowel will land up fermenting whatever is within, either secretions or food, and they'll end up creating a lot of gas. Which gas is it mainly? It's hydrogen sulfide. All of these land up causing significant proximal distension of the bowel before the obstruction. What's happened to the distal bowel? Well, you can see it's actually reduced in size after evacuation of all of the luminal contents from those early increased peristaltic waves. Let's quickly talk about proximal versus distal obstructions. When the level of obstruction is very proximal, you're going to have early vomiting and early dehydration. The abdominal distension will actually not be occurring. Think about it for a minute. The amount the abdomen is distended is going to be directly proportional to the length of the bowel segment proximal to the level of the obstruction, right? Like say for example, there is an obstruction at the D1 or D2 level. Is the stomach really going to expand to such a large capacity that the entire abdomen gets distended? No, there's going to be some epigastric distension, but it won't be as pronounced. This patient is going to have very quick early vomiting, severe dehydration, and then they're going to have dyselectrolytemia in the form of hypokalemia, hypochloremia, and these guys also, because they're losing acid, land up becoming alkalotic. In contrast, when you have a distal obstruction, the length of bowel proximal to the obstruction level is quite long. So the capacitance of the bowel has now increased to be able to accommodate all of the increased intraluminal contents, the fermented matter, the swallowed air, the biliopancreatic, gastric and salivary secretions, as a result of which these guys don't have vomiting early, rather they have distension as the main issue. Vomiting occurs late. And when vomiting occurs in such a situation, it's a sign that the obstruction has actually progressed quite rapidly and is now involving the entire abdomen. The other thing that happens is third space losses. Because the length of bowel is longer, the total amount of intraluminal contents is higher. These intraluminal contents land up just by osmotic action, driving fluid from the vascular compartment to the intraluminal compartment. So you do land up having dehydration in patients with distal obstruction, but the pathophysiology is different from those with a very high obstruction. Let's quickly come back. The proximal bowel segment is now severely distended. We've spoken about why exactly it's distended, and the distal bowel segment has now completely gotten emptied out. The obstruction is just as it was earlier. It is absolute mechanical obstruction. Well, at some point in time, the intraluminal pressure is greater than the capillary pressure within the bowel wall. These patients now start having mucosal ischemia. The mucosal function is lost, as a result of which there is more translocation of bacteria across the bowel wall. Essentially, that enteric barrier function that is performed by the mucosa is lost at this point in time because of hypoxia. This also produces a change in pain. The mucosa is ischemic. Over a period of time, the entire bowel wall will start getting congested and ischemic. The colicky pain that had subsided earlier now comes back, but it's not exactly colicky. It's more ischemic in nature, which means the pain is going to be constant, dull, and progressively worsening. There is this pathogen party that occurs as a result of loss of the barrier function. The first thing that happens is an increase in absolute number of bacteria. Not only is there an increase because of fermentation and unchecked proliferation of bacteria, there's also a change in the composition of bacteria within the proximal lumen. At this point in time, when the obstruction is well set, it is mainly E. coli, Klebsiella, and Strep fecalis. There are several reports of translocation of bacteria actually causing systemic sepsis, even in the absence of patient having an outright perforation. Even so, current recommendations are that patients in intestinal obstruction really don't benefit from systemic antibiotic therapy unless we know for sure that they are being taken up for surgery. But even so, a lot of surgeons do continue to give parenteral antibiotics to patients with acute or subacute intestinal obstruction because they are worried about this translocation of bacteria that occurs in a large dilated segment of the bowel. Now, say the venous congestion is not sufficient for a patient to eventually develop a perforation. Well, there is going to come a point in time where the intraluminal pressure is higher than the arteriolar pressure. At this point in time, definitely the bowel vascularity is going to be compromised, and these patients will end up developing this sort of a time bomb feature where the bowel may perforate at any given point in time. So it is not just a constant stretch on the bowel because of an increase in intraluminal contents. It is also the progressive worsening of the bowel's vascularity that precipitates the perforation. It's not just about pressures, guys. The physiology of the bowel wall is also altered as a result of increasing pressures. Now, let's talk about standard single point obstructions versus something called closed loop obstructions. When we're talking about single point of obstruction, the proximal segment can decompress more proximally as the obstruction worsens, right? Essentially, if you have, say, a level of obstruction within the rectum, you have all of the colon, and if the IC is incompetent, or rather, let me change that. Say you have an obstruction in the terminal ileum, then you have the entire length of the small bowel as well as the stomach to eventually dilate and accommodate all of this increase in luminal pressure. So the pressure equalizes more proximally. But when you have something like a closed loop obstruction, as you see on screen, where a loop of bowel is obstructed at both proximal and distal ends, well, that produces extremely high pressures within this closed loop. This happens very early and this happens very rapidly. Now, you can imagine that eventually this entire area is going to be having dilatation even in the proximal segment. But this occurs very late. and this is not the main problem. Now, you may land up having a time bomb within the proximal limbs when you're dealing with a single point obstruction as well as a closed loop obstruction. But in a closed loop, the loop itself is more like a nuclear bomb that's waiting to go off because the pressures are just so much higher than the intraluminal pressures within the proximal bowel loops. So closed loop obstructions actually merit early intervention and a very close clinical examination to be able to detect them. Where exactly are closed loop obstructions seen? Well, the classical example is hernias, be it internal or external hernias, right? The orifice itself lands up entrapping all of the bowel within it. So the bowel is stuck even at its proximal and distal end. And that entire bowel length within the hernia, the enterocele, acts as a closed loop. The other place is a volvulus. Most of us in our residencies would have come across a patient with a sigmoid volvulus. You go in, sure, the rest of the colon is also dilated, but it pales in comparison to just how dilated the sigmoid volvulus itself is. Infrequently, even adhesions can land up causing a closed loop obstruction in a patient who's previously been operated. And slightly more infrequently, a certain colonic obstructions can function as a closed loop obstruction. Let's see how. Now, in this diagram, you are having an obstruction close to the hepatic flexure. Now, you can notice that all the luminal contents from the IC valve are actually finding their way into the cecum and into the ascending colon, but they are not able to make their way into the transverse colon as a result of the pathology that is causing the obstruction. Over a period of time, this entire segment on screen will end up undergoing significant dilatation and the intraluminal pressures are going to increase. The IC valve here is the main issue that does not allow decompression of the colon into the small bowel. In about a third of individuals, this IC valve is absolutely patent and unidirectional, which means when these patients, about 1/3 of patients, when they have colonic obstructions, the entire colon from the point of obstruction back to the IC valve lands up functioning like a closed loop. The pressures increase significantly. This cannot decompress proximally. And in most situations, it is the cecum that lands up bearing most of the brunt. And there is a particular reason why. Think back to what we learned in our 10th and 12th standards way back in school and college. There's something called the Laplace law that states that wall tension is directly proportional to the radius of the container, to the pressure within it, and is inversely proportional to wall thickness. Now, let's talk about this. Wall tension will essentially be a predictor as to when this area is going to perforate, right? So the cecum underperforms in this situation in several ways. The first one is radius. The cecum is usually the most distensible and widest part of the colon, which means that the pressure over here is going to be dissipated maximally. That increased pressure is also going to worsen the cecum's chance of a perforation. The cecum is also one of the thinnest areas within the large bowel. This is made even worse because as the colon progressively dilates, it is the cecum that lands up distensing more and more. And as the cecum becomes thinner, the wall tension lands up increasing progressively. So the cecum is the most common area where you land up having a perforation when you have an intact IC valve. And even in certain cases when the IC valve is incompetent, where the colon is able to decompress slightly into the small bowel, even there, it's a cecum that bears the brunt of these obstructions. So even in a natural setting with a single point obstruction, you can land up having a closed loop within the large bowel. What are the non-intestinal manifestations of these obstructions, right? The first thing is the venous return from the lower half of the body is actually reduced. So not only is there more venous congestion of the abdominal viscera, but you'll end up having venous congestion even within the limbs. This is particularly worse for patients with cardiovascular comorbidities. They'll end up having significant fetal edema, and the increased fluid losses within the interstitial space actually worsen their dehydration. The reduced venous return as a result of pressure on the IVC lands up worsening a patient's renal function. Now, this is also adding to the patient's pre-renal dysfunction, because remember, these guys are dehydrated. So now there's a post-renal as well as a pre-renal cause of dysfunction that eventually causes acute renal injury and azotemia to boot. An often not discussed consequence of bad obstructions, particularly distal obstructions, is the elevation of the diaphragm that occurs with an increase in the intra-abdominal pressure. The diaphragm presses up, the lower zones of the lungs are compressed, they'll end up having atelectasis. Remember, these are patients who are also suffering from nausea and vomiting. When they vomit, they have a high chance of aspiration that again can increase their chance of pulmonary complications. There are 4 cardinal features of obstruction: colicky pain, nausea, vomiting, abdominal distension, and absolute constipation, which is constipation to both feces and flatus, which is also termed obstipation. Let's tackle these one by one. Colicky pain is often the first feature that patients will end up having. The location depends upon where the obstruction primarily is. Say you have a small bowel obstruction or an obstruction that is going up till the transverse colon. Well, this is a midgut level, right? So you'll end up having periumbilical pain. But if it's a more distal obstruction, say rectal, then the pain is going to be more hypogastric. It'll initially be colicky, then it becomes silent, and eventually a continuous type of pain heralds bowel ischemia and as a harbinger of perforation. Always beware the pain that is not responsive to analgesics. This means that a patient may be on the verge of developing a strangulated obstruction. Nausea and vomiting occur particularly early. In a proximal obstruction, we've discussed this earlier, the fluid losses are rapid and severe. These patients are extremely dehydrated and they develop a standard set of electrolyte disturbances, the first of which is hypokalemia. They develop hypochloremia, and because again they are losing acid, they develop alkalosis. And since you're doing an arterial blood gas for these patients to diagnose all of these dyselectrolytemias in an emergency, remember the ABG will also show an hematocrit that is elevated as a result of the dehydration. The abdominal distension that you experience is directly related to how long the intestine is proximal to the obstruction. So proximal obstructions, distension not so much, but distal obstructions, yes, distension is one of the main features after pain. Let's talk about closed loop obstruction and how distension occurs in that setting. In a closed loop obstruction, it is that main loop that undergoes dilatation. Now that may be a particularly long loop, such as if a patient is having a sigmoid volvulus. Again, think back to those crazy diagrams of big volvuluses, or maybe you've seen these in your residency yourself, massively dilated sigmoids. But a closed loop obstruction can also be particularly small, right? Say an obstructed or strangulating femoral hernia where the contents are fairly short. It is a closed loop that strangulates very quickly. We don't really talk about the strangulation and distension that occurs within the proximal loop, because these patients usually get operative intervention much before the proximal loop has a chance to sufficiently dilate. So large abdominal distension or significant abdominal distension may occur in a patient with closed loop obstructions, but it's infrequent. And if it has to occur, it occurs fairly late. Obstipation is one of the cardinal features of obstruction. In fact, if you ask an undergraduate student what is the main feature of obstruction, this is what they are going to be talking about. Remember, when patients come in to the ER with obstruction or they say constipation, the distension is not that bad, please don't give an enema early on. because they may have had either diarrhea earlier or they would be yet to have the diarrhea as a result of increased peristaltic activity. You giving an enema is just going to confuse the entire clinical picture and may end up delaying the diagnosis and causing the patient a lot of pain and discomfort later on. So please don't give enemas. Uh, there are a few situations where absolute constipation is not seen. You don't see it in gallstone ileus. This is when a gallstone has migrated to the terminal ileum through a fistula in the duodenum. This ball-like structure within the terminal ileum acts as a ball valve of sorts and keeps going back and forth within the terminal ileum and causes a waxing and waning nature of obstruction. So in gallstone ileus, very often absolute constipation not really required. In a Richter's hernia, you'll end up having only a part of the circumference of the bowel stuck within the hernia. So the lumen is still continuous. So it's something like this, and this is the hernial segment over here. So remember, the lumen is still continuous and it's okay to not have absolute constipation in these cases. In an intra-abdominal abscess, you'll end up having a localized ileus of the small bowel that is right next to the abscess. May not even be a complete mechanical block, but it definitely functions like one. Because it is a local ileus, you may still have a complete luminal patency, and these patients will very, very rarely have obstipation. They usually have some amount of diarrhea associated with this as well. And the last one is partial obstructions like strictures and malignancies, where the patient does have most of the features of obstruction, the other three, colicky pain, may have some evidence of vomiting, may have some abdominal distension, but obstruction may not be absolute because the lumen is not entirely compromised. It's just that it's been narrowed. So some contents may still pass through. We're going to quickly talk about the different levels of obstruction. Once again, to revise, proximal obstructions are acute. Distal obstructions have a more protracted clinical course, may present late, and patients will end up tolerating these obstructions a whole lot better than the proximal ones. Vomiting occurs early, and it is the fluid losses in vomiting that are essentially responsible for the dehydration as well as dyselectrolytemia. Vomiting occurs fairly late, and the dehydration occurs not because of fluid losses out of the body, but fluid losses within the intestinal lumen. So this is a third space loss that occurs. Dehydration is fairly late in distal obstructions. Proximal obstructions, of course, have less distension, less of the bowel is involved proximally, whereas the distension is quite severe and pronounced. In a distal block, the pain in proximal obstruction is much worse than those seen in a distal obstruction. So this was a quick recap. When you perform a clinical examination of a patient with intestinal obstruction, you need to have certain aims in mind. The first thing you want to do is diagnose the issue correctly. The second thing you want to do is rule out any strangulation. A clinical exam is also imperative to decide the timing of intervention, because it is not just a single point clinical exam that is important in these cases. You need to be able to figure out how the patient has been doing over a period of time. A vast majority of these patients will undergo a short conservative trial early on. So you need to see the graph of their pulse, BP, what their abdominal findings are, to be able to make an informed decision as to whether this patient is eventually going to need surgery or whether you're going to continue with conservative management. What exactly is constituted within the clinical exam? Very easy once we consider the standard headings. On inspection, you're going to check what's happening to the abdominal distension. In fact, in certain patients, you may be able to visualize the peristaltic activity if the patient is particularly thin and the obstruction is severe. You want to check out what scars, sinuses, and stomas the patient has. Remember, past operative history is going to be a great contributing factor to your decision making. The patient may have an incision hernia that is tender, that could be the inciting cause. or the patient is having a stoma with a parastomal hernia that is causing problem, or maybe the patient is having a volvulus around the stoma that is an issue. You will also get an idea from past surgeries, what the likelihood of a patient having an adhesive obstruction is. So you have to have a look at the patient's abdomen. And last but not least, you have to check all of the hernial orifices of the patient. There is nothing worse than sitting on a patient with intestinal obstruction, resuscitating them, and having forgotten to check their groin and realize they have a small obstructed hernia that's causing this entire mess. So that's not a laparotomy, that's a small inguinal exploration. So don't forget to look at the hernial sites when you're seeing these patients. On palpation, please check for tenderness. If a patient is having a well-defined local area of tenderness, then most likely this patient is veering towards strangulation. On auscultation, these patients have exaggerated sounds called borborygmy very early on. But remember, I mentioned that these hyperperistaltic waves may actually completely die off, signaling that the obstruction is progressing. On PR exam, you want to check if there are any feces. Is the rectum roomy? And is there any blood? This is the bare basic thing. The old saying goes that if you don't put your finger in the rectum, in a case of obstruction, you're going to land up with a foot in your mouth. I just want to draw a quick graph to give you guys a visual representation as to what happens with pain. The x-axis is time, and the y-axis is going to be the pain level of the patient. So very early on when a patient develops pain, there will be some amount of colicky pain that will keep getting worse in magnitude and will keep waxing and waning. But once the bowel is dilated beyond a certain threshold, this pain suddenly drops down. It may not become absolutely zero, but it will be a quiet abdomen as compared to the clinical symptoms that the patient had come with earlier. Now, this period may last from anywhere from a few hours to a couple of days. But as strangulation and ischemia start setting in, the pain becomes severe, constant, and at a given point in time, the patient develops peritonitis. That signals that strangulation is complete and the patient is most likely perforated. Keep this in mind when you're looking at these patients. Don't just think that an absence of colicky pain is a good sign and that mild central abdominal pain can be ignored. Think of this graph when you're checking your next patient that's being managed conservatively. What about the examination findings in a patient who's developing ischemia and strangulated? These patients are often febrile, they are tachycardic, and they are hypotensive. So you're going to say, doc, all patients of obstruction are tachycardic and hypotensive. Well, these guys, they stay tachycardic and hypotensive despite resuscitation. When you perform blood investigations, these guys will have leukocytosis. Remember, a patient may have hemoconcentration early on, so your initial blood reports, the CBC will reveal an elevated TLC. You want to check whether the patient has persistent leukocytosis after they have been adequately hydrated. All right. The absence of leukocytosis does not mean the patient does not have strangulation, but if their counts are raised, it definitely leans more towards the patient having progressively worsening obstruction. And finally, if the patient is developing worsening lactic acidosis, this is one of the sure signs that strangulation is setting in. There could be a few different causes for strangulation. One could be an increase, There could be a few different causes of strangulation. One could be increased intraluminal pressures rising above the capillary pressure. It could also be because of reduction in mesenteric blood flow. This is seen in volvuluses, also seen in intussusceptions. The last one is external compression. Classically seen in hernias and adhesive bands. Let's quickly go over the different investigations. Even though in our hospitals we are told you're supposed to get abdominal erect x-rays for intestinal obstruction, guys, that's not really the case. Supine x-rays are absolutely fine. Remember, patients with intestinal obstruction are those who are dehydrated, hypotensive, and in significant pain. Mobilizing them is probably not a good idea in an acute setting, and making them stand could be a legal liability somewhere later. Importantly, the diagnosis is obtained very easily on supine films if you know what you're looking for. So let's take a look at this film on the left. I'm going to change my pen color very quickly. So you can see the small bowel is significantly dilated over here, and there is no colonic air anywhere. The pelvis is entirely free, the two flanks are free. This is one of the first things I look for when I'm looking at an X-ray for obstruction. Is there colonic air? If there is, and if there still is an obstruction, it means that it's a distal obstruction. Whereas if colonic air is entirely absent, well, most likely I'm dealing with a small bowel obstruction, and that's definitely going to go some way in helping you plan your surgery. The same thing on the X-ray on your right. Can you establish that there is no air on the left side? There is still some colonic air in the vicinity of the cecum, but all of the air is contained within the small bowel over here. The sensitivity of a supine X-ray in diagnosing intestinal obstruction exceeds 80%. So usually the first line investigation in most centers, be it private or public. The stretch sign is particularly important. As the jejunum gets dilated, the valvulae connivans within it actually gets stretched, and you land up with this stack of coins appearance with multiple streaks occurring across it, which are so easily visible here. Another thing that you could perhaps notice on this X-ray is the several tacks that the patient has. Possibly this is adhesive obstruction from a previously placed mesh or a recurrence of the hernia. Not really sure, but the stretch sign is very easily visible over here. The stack of coins appearance, you can't miss it. If you do land up getting an erect X-ray of these patients, you need to have several air fluid levels for you to be able to make a diagnosis. How many air fluid levels depends entirely upon what mood your examiner is in that morning. There's no absolute set in stone objective number beyond which the obstruction sets in, or rather you can say that obstruction is set in, but there are a few signs you can look for. The first thing you can notice is within the same loop of bowel, you need to have unequal air fluid levels on the proximal and distal sides. Here, quite clearly, you can see one is actually longer than the other. The other thing you want to do is have a step ladder pattern of air fluid levels, and you want bowel loops to appear at least 3.5 centimeters across. That gives you, or rather helps you lean towards the diagnosis of intestinal obstruction. Please note that not all air fluid levels are pathological. You can still find them. I personally find this diagnosis to be particularly helpful. Unequal air fluid levels within a single loop, they'll end up helping you significantly. A string of pearls appearance can actually occur in fairly advanced obstruction. This is when small pockets of air start getting caught between the valvae connivans, and this air gets picked up as this sort of string of pearls sign on X-ray. If the obstruction is fairly bad and there is barely any air within the intestine is grossly dilated, that can actually create a sort of translucency or opacity that mimics a tumor which is why this sign is called the pseudo tumor sign. So you can appreciate there's a vague little border that is delineating the bowel from the surrounding area. So you may think that there's actually a soft tissue tumor, but essentially that's just badly dilated bowel with scant air inside. There are some specific signs for specific types of intestinal obstruction. The bird beak sign is classically seen in a sigmoid volvulus when you give them a barium enema. The volvulus is twisted upon itself, so you have a smooth tapering of the proximal rectum and distal sigmoid, giving this classical bird beak appearance. When you have an intussusception, you have some amount of contrast going in the ridge within the intussusception that produces the claw sign. Very frequent X-ray that is asked in MS general surgery exams. What exactly is the role of enteroclysis? And you guys must, especially be wondering, is it just of historical interest? Well, not really. Enteroclysis does have a specific role. You have to perform it, or rather I should say you can perform it in recurrent subacute cases where the diagnosis is still a little up in the air. It involves nasoenteric intubation, which essentially means you're having an NJ tube that's been inserted. You can see that on this associated X-ray over here. And you'll end up giving 500 to 1000 cc of dilute barium with methyl cellulose through this tube. Now, this is a slow installation and several films are taken over the course of the study. Now, there are several problems with enteroclysis. It needs expertise for diagnosis. And remember, it needs an NJ tube. This is essentially not a straightforward procedure. It means it requires preparation. It's slightly uncomfortable for the patient. It also takes a long time. And enteroclysis at this point in time has essentially been superseded by CT scans. Even then, when performed well, it lands up giving you a great picture and helps you diagnose at what level the obstruction is. And because it's a double contrast study, this is another important point, which means that you can also instill air within it. You'll end up getting a higher resolution of the image and your diagnosis is aided by that. Before I move on to CT scans, I want to discuss some other things. Specifically, what are the investigations you perform and what the findings are, right? So let's take this one by one. When you're performing a CBC, initially the hemoglobin levels, the WBC levels are all elevated. This is because the patient is going in is basically suffering from hemoconcentration. If the TLC is elevated even after resuscitation, remember that's a sign that the patient is having strangulation at this point. When we are talking about biochemistry, their potassium is going to be low, chloride is usually going to be on the lower side, magnesium also in most situations is going to be reduced. When you're performing an ABG, these guys are going to be suffering from alkalosis if they have a more proximal obstruction. And when you perform a stool examination, you're essentially sitting and checking for occult blood. This could mean one of several things. The patient could be suffering from a malignancy, an intussusception, or has suffered a strangulation at this point in time. So basic investigations you need to check off. Remember, during the course of a patient being admitted with acute obstruction, you're going to keep repeating their CBCs and you will definitely keep repeating their biochemistry. These patients may also have prerenal failure, so you need to keep that in mind when you're sitting and giving these guys potassium and giving them any sort of antibiotics. Okay, let's move on to CT with IV contrast. Again, don't give contrast if the patient is having renal dysfunction. All right. It's become the de facto investigation for intestinal obstruction because it helps you determine the level of obstruction, it gives you likely pathologies, it also helps you quantify in an objective fashion how bad the obstruction is, it gives you some signs of strangulation as well. We'll talk about that in just a bit. Overall, CT with IV contrast has a sensitivity of 95% and same specificity. So that's very, very accurate. They are able to pick up transition point in more than 9 out of 10 cases. So it helps you ascertain with great accuracy where exactly the level of the obstruction is. That goes some way in decision making later on. So what you will end up seeing is, let me just check the pen color. You will end up seeing this picture over here, dilated bowel segments. You also want to see what is happening to the colon. You can see here the colon is relatively, uh, say it's not dilated, it's flattened out. And you can appreciate the stretch sign is kind of manifesting itself within the small bowel. These small gas bubbles between these valvae actually manifest themselves as a string of pearl sign as the obstruction progresses. There are specific signs of ischemia. When there is bowel wall thickening greater than 3 millimeters, it means that edema is fairly bad and the bowel is eventually going to be hypoxic. It's one of the proxies for ischemia. You will also end up having mesenteric edema. Interbowel free fluid is always a bad sign. It's not going to be a loculated ascites. It is going to be areas which are having early ischemia. And the last bit is actually the most important. When you're sitting and looking at bowel wall enhancement, when it is heterogeneous in nature, it means that certain segments of the bowel wall are getting more contrast than the other. Ergo, the vascular supply to some segments is better than the rest. Well, the rest are actually now ischemic. Pneumatosis intestinalis means that there is free air within the bowel wall itself. This is a fairly late sign, and these patients are going to be very quick to perforate. And the last one is mesenteric or portovenous gas. Always a bad sign. These patients have an extremely high risk of mortality very soon after surgery. Now, if we sit and plot what's happening to ischemia over time, you'll realize that yeah, ischemia keeps getting bad. At some point in time, it's going to reach a threshold and it's going to cause an infarction, right? That's where it's going to perforate. But remember that it is not an absolute infarction which is irreversible. Actually, the late stage of ischemia is also irreversible. Where does CT actually come in? It helps us pick up findings in this part of the graph over here. You can see it is absolutely at the edge of when your irreversible ischemia ends, which means that if you're having any doubt regarding the viability of the bowel and whether the patient is now having a strangulating obstruction, you can decide to go in for surgery just on the basis of your clinical judgment and the patient's graph of either improvement or deterioration. You don't necessarily have to subject the patient to a scan and then wait for the reporting to be able to make that decision. So changes seen on CT, which are the most common ones that we are sitting and looking at? Heterogeneous enhancement and pneumatosis. These both occur very, very late. So please don't wait to make your decision on the basis of a CT. Now let's talk about contrast in a more therapeutic form. All right. So you definitely can give an oral contrast challenge, but there are certain criteria. The patient is not going to be having a full-blown severe obstruction. It's usually of a lower grade. It is simple, which means the patient is not having a strangulated obstruction, and usually small bowel obstructions. Don't try to give an oral contrast challenge in the large bowel. Okay. If the patient is not having a resolution of symptoms within 48 hours of conservative therapy, consider giving the patient a contrast challenge. How do you actually perform this? Well, you take 50 to 100 cc of contrast. It's given through the RT and you shoot multiple films. classically at the 8-hour mark and at the 24-hour mark. Sorry, let me just go back. Yeah. So now what is the predictive value? If you see no contrast in colon at 24 hours, these patients are good candidates for surgery. They're going to fail a conservative line of management. So the findings of this contrast challenge actually land up helping you. Now, important point, see, no contrast in the colon. Obviously, if you have a colonic obstruction, then you'll have some amount of contrast going into the colon, right? So please don't do that. It's going to be an issue. There are several advantages of an oral contrast challenge. The first of which is it is hygroscopic material. So contrast actually seeps out some amount of fluid from the bowel wall into the lumen, reduces bowel edema. This is particularly useful in obstructions in the post-operative course. A patient is having an inflammatory condition or is having a waxing and waning sort of subacute recurrent obstruction. So a reduction in bowel edema can actually reduce or rather impede the obstruction from going ahead. It has also been found to reduce the need for surgery as a result, and has been associated with a shorter hospital stay. The contrast challenge is amazing, but it definitely has some contraindications. Does the patient have features of peritonitis? Please don't give an oral contrast challenge. Do you have suspicion of strangulation? Then this is not going to make sense. Does the patient have severe acute obstruction? Not going to make sense either. Does the patient have a colonic pathology causing the obstruction? Okay, think back to the diagram of the colonic obstruction with a competent IC valve. Now, clearly, if the patient is having, say, an obstruction in the level of the mid-colon, most of the contrast from your contrast challenge is going to land up going into the large bowel, right? With a competent IC valve, none of this contrast is going to reflux back into the terminal ileum. What's going to happen is the contrast will cause more and more movement of fluid into the lumen of the colon, increasing the intraluminal pressures, and has actually been associated with a higher risk of colonic strangulation in the long term because of these increased intraluminal pressures. So if you're suspecting a colonic malignancy causing an obstruction, it makes way more sense to actually give the patient a contrast enema, right? Don't sit and give contrast via the mouth. Think about how many meters of intestine the contrast has to go across to be able to reach the transition point, but you only have to go across a foot or two when you're going in through the rectal route. So do the logical thing. If it's a distal obstruction, do an enema instead. Don't try to give oral contrast. It's going to cause problems. Okay. General treatment of obstruction, be it small or large bowel, is all the same. You need to give fluids and electrolytes. So most likely the patients get normal saline, Ringer's lactate. You will end up giving potassium to all of these cases. And if they are alkalotic or acidotic, you'll end up giving correction on the other side. Tube decompression is very important. Usually, it's a nasogastric tube which is inserted. There were people who used to advise a nasojejunal tube for decompression early on, but these have actually not been found to be helpful at all. They are more invasive, increase the complication risk, and if they're not giving you any benefit, not worth the intervention, right? Now, antibiotics is a big question. As far as guidelines go, antibiotics only to be given to a patient if the patient is heading for surgery. Most of these cases are going to be CDC class 2, 3, 4. But remember, there is translocation of bacteria across the bowel wall right before strangulation is setting in or in advanced obstructions. Patients have been known to go into systemic sepsis as a result of bacteremia. So in severe obstructions, I think it makes sense to just throw everything at the patient, including the kitchen sink and a few antibiotics, but that's just my personal opinion. Guidelines say not required unless there is surgery. If you're thinking about ending at the general management, just a conservative line of management, then the patient has to meet certain criteria. The patient should not have a fever, should definitely not have tachycardia after resuscitation. The patient should not have tenderness, which leads towards strangulation. Leukocytosis should not be escalating. Isolated elevated TLCs are fine, but a worsening TLC definitely is leaning towards strangulation. And you should not have worsening of these patients on X-rays. Extremely important, cannot be understated.